damage. We now have outpatient surgical centers that don't want to perform D&Cs for for miscarriage, because it's so complicated, the things that they have to do and the loopholes they have to jump through with products of conception. And literally, we have a surgical outpatient center here in northern Utah that has suddenly said, we're not doing D&Cs for anybody anymore. We're just tired of doing it. It's too much trouble. It's too costly to deal with all this pathology stuff and all the rules around fetal remains. So now patients are forced to either choose medical management of their miscarriage at home, which can be painful, and some women just don't want to go that route. They'd rather have a quick surgery. Or they are going to have to go to the main OR, take away block time from major surgical cases, have major general anesthesia instead of local. So it really does impact care, and I think it's important to know that.
Should we skip some
Yeah.
of the other stuff?
Yep. Which should we skip?
Oh, actually, no, right there.
Yeah.
We can do that real quick.
Okay. So again, I think just to summarize, we wanted to remind everyone to use guiding principles and just practice evidence-based medicine. We're grateful to live in a place where we can still do that for right now. Treat ectopic pregnancies, including cesarean scar ectopic pregnancies, per standard of care. Those are not considered abortions. You don't need to worry about any of the nuance of the law there. And that the circumstances preceding patient presentation do not preclude the provision of care or implicate the physician in any way in assisting in abortion care. So do the right thing when the patient shows up to keep her safe, and that's the right thing to do. Good.
Okay.
Sorry, we just have so much to say.
All right, so this is going to be pretty quick. But in terms of preventing unplanned pregnancies, we should assume that patients may be sexually active and counsel all patients about contraceptive and ask if they have a need for that. Part of chronic disease management and care of patients on teratogenic medications is to address contraception. Never assume that patients cannot get pregnant. Offer referral of medically complicated people to, we have what's called a PREPARE clinic, which stands for Pregnancy Prevention Planning and Risk Evaluation, where we do complex contraceptive counseling as well as preconception counseling. And offer emergency contraceptive to all sexually active young people. You'll have to have us back if you want to hear more about all of the contraceptive options and about how great they are in different medical conditions and which ones you can use when, because we're going to run out of time. And I want to save time for that, but these are your emergency contraceptive options in order of efficacy. Provider advocacy efforts. There's lots of ways to get involved. This is something we are going to talk about a little bit more in our breakout session if people are interested. We're also happy to talk about whatever you want there. We have some prepared material, but are happy to also just riff on whatever you all want. But these are some ways to get involved. And we want to say thank you to everyone who signed this message to our patients, many of you in this room, after the Dobbs decision, committing to our care of them and their reproductive needs. Resources, we're going to skip that because these things, I want to say if anyone has questions, but these are things that you can refer to in the slide deck if you need extra resources or referrals to get help for your patients. Thank you.
I went on too long.
That's okay. I know we're at time. We're happy to stay if anyone has questions, but I don't want to take up, I want to be respectful of the conference time as well.
And people like to eat lunch, and we understand that too.
All right, well, thank you to both of you. Oh, we got a question. Thank you.
A remarkable presentation. I thank you very much for that. It boils down to me, you used the word ethical about over 12 times. I counted them. I don't know what that means. And it all depends on what your definition of beginning of life is. And I'd like to know what your answer to that would be. There have been over 162 million abortions in this country. That's a lot. And you were only talking about 1% of them, the difficult ones that you guys met. There's a lot of them that you wonder about as far as ethics go. Thank you.
Yeah, I use ethical as in line with my own morals and values, and everyone's different. So when I say I feel ethically bound, I mean that they are in line with my own values and morals. I actually think respectfully that when does life begin is not quite the right question, and I'm happy to take this offline a little bit. But I think the question is, from a legal perspective, when do the rights of the pregnancy supersede the rights of the pregnant person? That's the legal question. Because religious scholars, legal scholars, moral scholars have all tried to define when life begins, and they cannot, so I can't either. So I think it's a very individual decision that each person needs to make for themselves.
I also want to thank you for your presentation and for some of the work that you've actually done with the legislature. There are some things with wording that very much does need to be changed in abortion law in the state of Utah. There are situations where abortions need to be available to people. I do have one thought, though, and that's once something, well, to a nephrologist, everything looks like a kidney. To a cardiologist, everything looks like a heart. For a provider that provides abortions, everything starts to become, well, would an abortion be better in this situation? And it's really easy for medical opinions to actually sway. I can think of 3 situations, which I'm not going to go through here, where reproductive coercion came from the provider, not from the woman or the man or anybody else that was involved in that. So I know that you both have values in terms of life and honoring life. And I would just urge you to be very careful, when you're arguing for abortions, that you don't overstep certain lines and make everything look like an abortion, because that is easy to occur.
Sure. I think to speak to that a little bit, I think the most critical thing that we do with our patients is to present them with all of the options, walk them through what every single one of them looks like. And literally I use the words, my job is to tell you all of your options and to help you walk through what's right for you and for your family based on your feelings and values about what these things look like for you. Right? That's the principle of this. It's not trying to dissuade a patient one way or another. I've cared for many women who've continued pregnancies that I was desperately afraid for them to continue. And what I tell them is, and in fact I can think of one in the last year who had complex congenital heart disease. And I spent the first 12 weeks trying desperately to help her understand how high her risk was and that the medical recommendation would be to terminate, but with the clear understanding that I will care for you no matter what. And she decided, I'm continuing no matter what. And I said, I am on your team. We got this. We're going to do everything we can to keep you both safe and healthy and alive. And we did that. And it was a lot of luck and some great cardiologists and a team of people. But that is every single decision. It is not you making the decision for your patient. It is not allowing our own bias, what I think would be quality of life for my child, to influence how I counsel someone else about what they believe is quality of life for their child. That is what it's all about. It is about autonomy and family choices. It is not about us telling people what to do, but it's also not about not offering genetic screening to families until it's too late for them to do something about it because you don't want to see them decide to have an abortion, because we see a lot of that too. So I'm just saying that does go both ways. We see a lot of women where physicians also assume, oh, this patient would never terminate. Well, here's the other thing. If you can be really, truly unbiased and open the door to patients to make their own personal choices, I wish I could tell you how many times we've had women say to us in tears, I can't believe that in 24 hours my entire concept of what abortion even means has been completely upended. I am pro-life. I've always been vigorously pro-life. How can I possibly be looking at this? And how is this an abortion in the way that everybody says it is? So these are very complex decisions. I don't think that we spend almost all of our time trying to help people stay pregnant as long as they can and have healthy babies. Like, that's my job. I'm a high-risk specialist. I want a healthy mama and a healthy baby at the end of the day, and there's lots of ways to get there, and that is our goal every single day. I wouldn't have done MFM if all I wanted to do was provide abortions. It's really not that, right?
Yeah. For me, the ethical thing is honoring what the patient's values and morals are and helping them achieve those goals for themselves. But yes.
I just wanted to say thank you. I think that you your occupation and your choices in this are incredibly complex, and I think you do it well. Anyway, and as a mom, a wife, a physician, an engineer, I personally look at this more systems-based, and biology is a lot more complicated than I'm trying to find the right words. Anyway, I'm not succeeding. Anyway, thank you.
Thank you for saying that. It means a lot. It is a little daunting to stand up in front of a room of 100 people you don't know and talk about a concept like this. That's why we came together. Moral support. But yeah, and I do think that this is a really complex issue that I have struggled with over the years. I mean, I don't want to take up too much time, but I can tell my story of how I came from a resident being like, I don't think I'll do this when I'm an attending. Like, I don't like this, to standing here before you. And it was an evolution. And I think that we have to lean into the gray area. And that's all I'll say about it.
I would like to say thank you. And I hate to talk in front of people, and I'll be really quick. But I think that sometimes in medicine we learn the most from our patients, and so I'll be really, really fast. I had triplets, and so I had an extremely high-risk pregnancy, and I experienced some coercion from my high-risk specialists. And they sat down with me mostly when my husband wasn't with me, so I didn't have support, trying to get me to terminate my pregnancy, to say, yes, we can take 2 out and leave 1, because it will have a higher possibility of having 1 succeed, right? And it'll be less of a burden on the financial society, and it'll be less of a burden on the NICU, and there's a high risk for intraventricular hemorrhages in premature babies that are under the gestational age of 30 weeks, and on and on and on. And then they started having the NICU nurses take me through the NICU and basically treat me as if I didn't know anything about medicine or about what the decision I was choosing to do would mean. So I think that it's really important that when we are talking to our patients about these things, that what you said, I really appreciate what you said, where you're like, we're presenting the options, and that's what we're doing. We're educating our patients, and that it doesn't come across as coercion, it comes across as education. And so that's all I'm gonna say. But thank you again.
Yeah, thank you for that comment. And I apologize on behalf of our profession that was your experience, because that I wholeheartedly agree with you. That is not how this should work.
Yeah, to the same, echoing that. And, you know, sometimes it's really hard to find the balance with, I wouldn't say necessarily in that situation where you like might discuss that one briefly. And by the way, that's no longer standard to even option or offer, because the outcomes are just as good, so you don't even offer. But is to say that there are cases where you're so worried about a woman, and I use something we call meta-communication, which is talking about communication. I say, look, we're going to talk about some hard things. At the end of the day, we're going to circle back around, and we're going to figure out what you want to do. But I need to talk through these things, and then we will circle back. And when you tell me that's not an option for me, I wouldn't consider ending the pregnancy no matter what, then we don't have to talk about it anymore, and that's great. And so sometimes we try to be very mindful about that. We also, I find, Dr. Heuser and I, we're very particularly interested in this topic of counseling and coercion and how to check your own bias, right? Because we all have it, and it would be idiotic to think that you don't. And so we go to each other sometimes too to try to check that. We always offer patients, would you like to talk to a different colleague? When we have our committee that talks about doing these approvals for severely life-limiting abnormalities, we try to come across the spectrum. We have folks on all ends of the spectrum in terms of, you know, their feelings about abortion care in general, religious background, all of it, to try to be as objective as we can. And I'm so sorry that you had that experience. It definitely happens. I mean, for sure.
Yeah, no, thank you so much, Dr. Eller and Heuser. It was wonderful to hear from you today. That is it for our morning. We're going to start our lunchtime, and I'm glad that some folks have already started getting in line. Our lunch is supported by our sponsor, our OSMS partner, Physician Wealth Advisors. Please stand if you're associated with them, or raise your hand. We'd like to honor you. Thank you. Oh, they're there in the back. And then, excuse me, I think Vice President Mark Woodruff will be speaking during the